Good afternoon or good morning for those of you on the West Coast. My name is Ann Greiner and I am President and CEO of the Primary Care Collaborative. For those of you who may not be familiar with the Primary Care Collaborative or the PCC, we are a membership organization that is multi-stakeholder and we have a diverse set of nearly 70 members. What our members share in common and what our work is informed by their views is a strong commitment to strengthening primary care as the foundation of a high-performing health system. I'm so pleased today to have a conversation about how we change how we pay for behavioral health integration. This is a topic that really has increased in urgency given the crises we're facing, both with mental health and also with addictions, opiates and otherwise. I'm so pleased of the panel that we have today discussing this topic. Purchasers, state leaders, health plans, who are themselves innovating to transform the way we pay so that we can support behavioral health integration. This topic is one that the National Academy of Science, Engineering, and Medicine report on primary care in 2021 focused on. If you recall, the first and most important recommendation in that report was changing how we pay and how much we pay primary care so that we could support teams to provide a comprehensive set of services. And behavioral health integration, the NASM report underscored, is the most evidence-based set of services that we need to integrate into primary care. Let me briefly introduce each of our panelists, and we're going to kick the conversation off. But before we do, next slide, please. I wanted to make sure that everybody who's joining us today knows about our upcoming conference. PCC does an annual conference. This will be the first time in 3 years where we're going to gather in person in Washington, D.C. on December 14th and 15th. The conference is Better Health Block by Block, and we're going to be looking at how the community, both the public and the private sectors, are embracing the recommendations in that NASM report, National Academy of Science, Engineering, and Medicine report that I just mentioned. So there's a registration link there, and we really hope to see you at the conference. Okay, without further ado, let me briefly introduce our panelists, and then we're going to get started talking about the current situation in terms of behavioral health integration and how it's working. So let me start off by first introducing Alan Severance. Dr. Severance is a psychiatrist. He is one of the co-chairs on PCC's Behavioral Health Integration Work Group, along with Mike Thompson, who I'm going to introduce in a moment. And Dr. Severance is a board-certified psychiatrist. He's medical director of behavioral health at the UPMC Health Plan and also associate medical director at Community Care Behavioral Health Organization. He continues to see patients in group private practice, and he's got a clinical interest in severe mood and anxiety disorders. And we'll go on a first name basis after I introduce everyone. Next, we're going to hear from Mike Thompson, who I just mentioned. He's the other co-chair of PCC's Behavioral Health Integration Work Group. And Mike is president and CEO of the National Alliance of Healthcare Purchaser Coalitions. We often refer to them as the National Alliance. And it's the only nonprofit purchaser-led organization with a national and regional structure dedicated to driving health and healthcare value across the country. For those of you who know Mike, you know how passionate he is about taking care of the whole person, including behavioral health needs. Prior to joining the National Alliance, he was principal at Price Cooper's Waterhouse, PwC, for 20 years. And he is a treasure. He's a nationally recognized thought leader for business health strategies and health system reform. Mike is actually an actuary by training, and has experience working in the mental health space. He was past president of New York City chapter of the National Alliance for Mental Illness, NAMI. Thank you, Mike, for joining us. Next, I'd like to introduce Dr. Judy Serzan-Thule, and Judy is the Chief Medical Officer of the Washington State Healthcare Authority, which purchases healthcare on behalf of the state's Medicaid beneficiaries as well as public employees. And you're going to hear about a lot of the innovation that's going on in the state under Judy and others' leadership. Judy serves as the newest executive forum co-chair for the Healthcare Payment and Learning Action Network, known as the LAN. And we know the sort of intellectual leadership that the LAN provides to the field, and we're really excited, Judy, to have you in that position. You've long been involved with the LAN, serving on the Care Transformation Executive Forum. So we know of your work, and we're excited to see you in this new position. Prior to serving as CMO for Washington State, Dr. Serzan-Thule, Judy served in the same capacity in Colorado, and she has so experience in a couple of different states, experience working with Medicaid, and really helping to provide thought leadership in the value-based payment space. And last but not least, I want to welcome Dr. Kevin Wheeler. He's Medical Director for Practice Transformation and Value-Based Contracting Strategy for the AmeriHealth Caritas family of companies. And I also want to welcome AmeriHealth Caritas to the PCC family. They're one of our newest members, and it's wonderful to have you at our table. He is a board-certified emergency physician and also practices part-time in underserved, rural, and critical access hospitals in northern New Hampshire. And that's one of the markets served by the Medicaid managed care operations of AmeriHealth Caritas. Prior to joining his current organization, he was Executive Director and Chief Medical Officer of the Boston Medical Center Health Plans product in New Hampshire. So welcome to all of you. And let me start by turning first to Alan to talk about our current payment models and how they support behavioral health integration or don't.
Thank you very much, Anne, and thanks for the intro. All right, so and we can actually put up that slide right now if you don't mind. So there are 3 CPT codes that are designed explicitly for collaborative care model services. That's important to know because there are other models of integrated care or partial integration out there that don't have explicit CPT codes tied to them. So there's an initial and a follow-up code, as well as an add-on code for time spent above the 70 or 60 minute per month threshold. For most situations, the minimum expected time requirements for each are half plus 1 minute, or 36 and 31 minutes per month, respectively. And the important thing to remember is that the only activities that count towards the collaborative care card codes are the clinical time that the behavioral health care manager spends with the patient, time that the care manager spends with other collaborative care team members, or time spent coordinating with outside providers, as well as the time doing outreach to the patient and time spent entering data into the registry tool to track patients' engagement and clinical progress. There is one other code, the 4th code, which is a general BHI code, which reimburses at a much lower rate, which is meant to support other kind of models of integrated care, such as primary care behavioral health, which is where you have an embedded psychotherapist that partners with a PCP to create care plans, provide brief interventions and other things. FQHCs and RHCs have a somewhat different financing structure, and they use G codes, although there's a lot of movement in this space in terms of how to adjust that. A lot of people have found that it's just not financially worthwhile above and beyond the sort of existing financing. I mean, the nice thing about these codes is that it supports clinical work by the primary care doctor and the care team that under old, kind of status quo CPT codes are just not reimbursable, or they're very poorly reimbursed, like behavioral screening, brief interventions, care coordination. Now, I work for UPMC Health Plan, which is based in Pennsylvania. We have plans for commercial, Medicare, special needs, Medicaid, pretty much throughout the entire state. We see a lot of different kinds of people and different needs, and like many places, there are definite health disparities regarding behavioral health, rural versus urban, ethnic minorities. It is not easy to find a psychiatrist, it's not easy to find a therapist. Collaborative care is a great strategy to sort of narrow those gaps, but we've seen extremely low utilization of these codes. I've actually had several practices approach me for guidance on billing and documentation. I know several practices that have been self-funding collaborative care for years. We're motivated to help them be compensated for providing high quality care because it allows them to sustain and hopefully expand their programs. But that's really hard in a multi-payer environment. We have competitor plans that are not reimbursing for collaborative care codes. So a clinic really has to think hard if they can kind of take that financial risk, knowing that not all of their patients are going to be able to be compensated for what they're doing. Even so, if you talk to providers, everybody feels like this is the right direction to go. They all want more integration. They want better access to behavioral health resources. It's just, how do you get from here to there? They don't have the knowledge, the resources, the time to begin their implementation journey. Having the codes turned on is just not enough, even if all plans do it. So we've been taking a more proactive role in promoting collaborative care, connecting clinics that are actually doing this with other clinics that are doing it so they can compare notes. We're talking about like a learning collaborative, sharing existing resources through the AIMS Center and other national organizations. And then something that the Primary Care Collaborative is focusing on, which I do think is really important long-term, is looking seriously at alternative payment arrangements. There's a number of approaches for this, whether through capitated or partial capitated payments, or just enhancing E&M CPT code rates for clinics that offer integrated care. That's something that we have not done very much yet, but I think that that's the direction that we need to go. So in the absence of people actually using these codes, what is currently happening is most practices fall back on their usual billing practices. That's E&M codes for a physician, or like a psychiatrist or prescribing clinician, and psychotherapy codes for anybody doing therapy, 90832, 834, 836, 837, etc. This is just the traditional co-location where you have services, physical health, behavioral health under the same roof, but it doesn't guarantee meaningful care coordination. You have separate documentation, separate billing, separate contracting. Treatment tends to be siloed. Also, there's no reimbursement for actual team-based care. So they might share the same office, they might be down the hall, but they might not actually talk to each other. And that's not the direction that we want to be going. I will pass the baton to my teammates because everybody has a lot to say.
Thank you so much, Alan. But I think when I heard your takeaway, and you're providing, you personally and UPMC are providing a lot of leadership in this space, that your competitors may not necessarily be in the same place, and that's problematic for the practices. And also, even when the codes are turned on, there's low utilization, and we could unpack that. So there's certainly a lot of challenges here. At the same time, we know that the patient need is quite intense. Mike, what's your view on how the current system's working?
Mike, you're muted.
I started by saying that's really a loaded question. We really have in the country, really, and we've had a crisis. This isn't a pandemic-led crisis. This is a crisis that existed at least for the last decade or more, and it's really a crisis of access to behavioral health services. People try to get access and they can't get it through their networks. They can't get it. They're going to the primary care physician, and oftentimes the expectation on the patient side is they will be treated holistically, but the expectation from the provider side is that's not my thing, right? That's not what I do. Or they offer medications, but they don't necessarily have the expertise to treat very complex conditions that require more. So, our sense, so we have an initiative that we are working on with a number of key stakeholders, looking at what needs to happen to improve access and quality of behavioral services. And there's no path forward that does not include integrating behavioral health into primary care. That's where most people are getting their medications today. That's where most people expect to be treated. And we know we have evidence-based practices that can work. I think the challenge, as we've gotten into it, is that payment and change management and leadership are probably the three things that are getting in the way. Payment in the sense that, yes, we need all payers on board. We need everybody to be in the same boat, rowing with the same oars. We need to turn on the codes at a minimum, but beyond that, we also need to think about investment in two ways. One, it can actually cost money to bring up these practices, and we've heard from providers that can be one of the barriers. And then, as Alan talked about, there's a change process. It really requires leadership to help practices go there. We have put a stake in the ground from a purchaser perspective, and you've probably heard me say this 100 times, right? That it is not an advanced primary care model if it does not have behavioral health integration. And behavioral health integration, as Alan said, is not simply having people in the same office. That's not integration. It requires systematic screening and treatment and follow-up to confirm that progress is being made and treatment is modified as accordingly, and appropriate triage when things are more serious than maybe can be handled by the primary care practice. So that team-based care and team-based model is fundamental. And frankly, we know we need to pay more, but it will more than pay for itself. And we know that practices that have implemented integrated behavioral health, at least the ones I've talked to, have said we will never go back. Once we experienced what this looks like, we realize this is better for patients in a big way, and frankly, it's better for the practice. So we just have a change management and a leadership challenge in front of us to move it forward. And yes, let's make sure we're paying for this high value service for practices to adopt.
Thank you, Mike. And it would be wonderful if all purchasers could lift up the banners that you lift up in your work. Judy, over to you.
Yes, thanks. So I work at the Washington State Healthcare Authority. We cover close to 2.4 million Washingtonians. The majority of them are Medicaid, but we also cover state employees, school employees, and retirees. So it's the whole spectrum. And I'm the chief medical officer there that sort of helps orchestrate some of this. And as Ann mentioned, I've been doing a lot in primary care in Washington State that I hope is advancing integrated behavioral health. And we've had, I'll start with some data because data is always fun. We have 88 practices in Washington State that do collaborative care for one of our plans, which is super small. And in order to do that, we do require an attestation that there is fidelity to the model of that at the beginning, but then you're free to bill. And looking at the data, and I looked at 2018 to 2020, so pre-pandemic, because the pandemic has made things everything a little quite funny, but we had just under 7,000 claims, and the total we spent was about $780,000. So really not a lot, and hopefully, you'd want more, because I think we do all agree that integrated behavioral health is the best way to go. And so in talking with practices of why not, I think it really boils down to sort of two challenges. One is model fidelity. This takes a lot of time. It's hard until you get into the groove, that sort of change management bit to figure out how to do this. I think the 30-minute code helps because that was sort of a later add-on to the collaborative care codes, but it's still hard and takes a lot of time and resources to do. And then the second thing is one that Mike mentioned, the startup costs. A lot of practice find that it's really expensive to start this. Once they get it going and once they're in a groove, billing for the codes keeps them self-sustaining, but it takes a little while to get there. And so that initial investment can be a little challenging.
Thanks so much, Judy. Mike, we've talked to Mike. Kevin, over to you.
Thank you. So I'm a medical director for practice transformation and value-based purchasing strategy for AmeriHealth Caritas. We're a Medicaid MCO company. We're in, I think, 11 states now with maybe 12 different Medicaid products. We also have some Medicare and exchange duals as well. So I have a number of thoughts based on my colleagues' comments here. Kind of based on sort of what we're seeing on the ground as far as direct interaction with providers and how these payment structures are actually, unfolding in real time as we go through the normal contracting life cycle and kind of come in and out of markets, et cetera. So that's sort of where I sit, this kind of an enterprise point of view, looking at overall what's happening with our interactions with providers, kind of what the prevailing trends are. And there are a number of them. I think many of them have been mentioned already. Change management obviously is a hugely important topic when it comes to any provider performance metric, any sort of alternative payment mechanism. This is one thing I say all the time throughout the company is the most precious resource for any provider is time. And so, the minute we're asking for more time, that's just the biggest ask we can always, deliver to any provider. So, there needs to be a fair exchange of resources in that space, and that is the support that we try to offer. So, to the specific question of kind of coding, billing, and how payment works. The way the winds are blowing, I think we all know this, is that the state contract requirements are very heavily weighted towards moving into APMs and moving into, capitated with quality, moving through the land spectrum, and pushing either spend requirements or number of lives touched requirements along the spectrum fairly aggressively, actually, year over year. And so as we do that, most of our administrative focus and our policy focus is in how to manage that and how to help providers be successful in those structures, and trying to kind of pull that thread between what we are required to do in our state contracts all the way to what is best for the member all the time. And there's a number of points along the way between those two spots that we run into kind of administrative static or burden, if you will, and we try to smooth those out as much as we can with providers. We try to have payer incentives aligned, for example. That's a huge one because we're a fairly small payer. We're also Medicaid, and it's just it's a very difficult challenge to say we have a set of incentives that's very different than everybody else's. So we try to have those incentives aligned as much as we possibly can. On the change management part, so much of that is communication and data transparency as well. And we're working very hard with our provider partners to have as much data transparency and as much performance transparency as we possibly can throughout the spectrum of size of providers that we work with. And we have a heavy focus in rural populations in states that have a large amount of rural medicine that goes on. So, that's materially a different endeavor than with the large centers. So we try to have as broad of an approach as we possibly can to doing the change management and kind of helping providers perform. I think the last point I would make, and I appreciate the time and introduction in very much, is that we're in a world now also of mandates to delegated care management, and very often the care coordination that takes place from our point of view and the care coordination that happens that we can facilitate and sort of impact the most is actually at the care coordination and care management level. And we are seeing quite a bit of push from the states to have that happen locally, and we support that. North Carolina is an example. There are a number of others. Louisiana also is aggressively moving in that direction. We expect Florida to do the same. And then I think one last point is that the marketplace itself is moving in this direction, I think, fairly aggressively. So we are seeing a lot of sort of hybrid provider vendor for-profit companies coming in that are acting as providers, generally with a behavioral health focus. But more and more so, they're saying, okay, we also have a care integration focus, and we have primary care services that we're also bringing to the table. And these offerings are compelling. They very often come with a fairly aggressive savings target that sometimes we have our issues with, but at the same time, the concept is there. They very often have a digital platform, and we're exploring these partnerships pretty aggressively, always with the idea of maintaining local resources as the first priority, but as the second priority, if we can enhance, we will. And I'll stop there. Thank you.
Wow. So I think our speakers have just put a number of issues on the table, although I would point out that there's a lot of trends that I think are cross-cutting. One is all of you mentioned the challenges of change management, helping the practices integrate behavioral health is not just something that you snap your fingers and it happens. There's a lot to changing the delivery system, to changing the culture, figuring out how you're not, kind of practicing, parallel play, but you actually are integrated, you have shared goals for the patient. All of that doesn't just happen overnight. And I think, Mike, you underscored that it also doesn't happen without investment, because maybe you are changing your floor plan to allow for more integrated care. Maybe you're thinking about, how do we, have the behavioral health folks, not, in a different building, but, right down the hall. So these all involve investment, maybe not in physical plant, in helping to folks to really practice as a team and to approach the patient in an integrated fashion, an integrated record. I mean, all of that is a whole set of actions. And then I think the other thing that was mentioned is, what's the payment model that can really support all of this? And I think we heard from Kevin in the Medicaid space that, there is a lot of forward momentum in terms of, APM agreements and, practicing in a more capitated environment. Which is kind of moving that along. And I think it's mixed in other environments. So those are sort of the themes that I heard. Now I'd like to, we kind of talked about our current, our current environment. I'd like more of a conversation, and we're not going to go around our virtual table. People can just pipe in. What do you think the future holds, and what are your, what do you hope? How do you hope we can move the country? And where are you putting your bets in terms of what's going to be most transformative in supporting behavioral health integration? So I'll just open the floor, whoever would like to jump in first.
I'll take a stab. So,
all right.
What I've observed, and frustratingly observed, is a lot of time we're spending more time debating what the model is and not enough time actually executing the model. I think we ought to just let's get away from labels and talk about what we need, right? We need to systematically be assessing. We need to systematically be triaging, short-term treatment, and then remeasuring and monitoring progress, right? It doesn't need to be co-located. It can be virtual. There are solutions that are virtual solutions. The change process doesn't need to be complex, in part because there are people you can work with that can help bring that up pretty efficiently if you choose to do that. Having said that, we are seeing pockets of progress that are transformational. In Texas, there's a major grant that came out to facilitate behavioral health integration in primary care in Texas. And I think it's called the Lone Star Project. And it's a major activity. In Michigan, Blue Cross of Michigan, of course, they have a dominant market share in the state of Michigan, but Blue Cross is actually making the investment. Remember that? How do we get over that hump so that the other side, we have something at the end of the day, but they're making the investment. I think the federal government has to step in and also lead with investment, because this pays for itself. There is so much cost to poor quality in ignoring behavioral health, and that's largely what our system does today. And cost of poor quality, if we mistreat mental health, it gets worse. And oftentimes people fall off the wagon if they don't get well the first time. I think we've got to be committed to a whole person a whole person approach that leads to the outcomes that I know the physicians want for their patients. And it's going to require some activity. But the good news is there is activities happening in the right direction. We just need to scale it and make it not the exception, but the rule.
So I think some of what we're doing in Washington State is some of the key, both thinking about multi-payer and thinking about payment change are the two big things that I think need to accelerate and have started in small pockets and need to keep going. So in Washington, we have a primary care transformation model that we've been having a number of different convening forums. One, and where it started, was with the payers in Washington State agreeing they wanted to support primary care, and in particular that integration and that piece of how do you get better behavioral health to folks, because what we're doing now isn't working. The second piece of that is there's a table for clinicians and health systems, and then recently we've added a table for purchasers or employers that also, to Mike's point, want this for their employees. And in that model, we have alignment of sort of approach to it. We have 10 accountabilities for practices, and those accountabilities include things like whole person health, behavioral health screening for every person, and then appropriate follow-up, a team for every patient. So all of these things that really are integrated behavioral health, as well as sort of care coordination and data, and all those other good things that make an advanced practice an advanced practice. Part of how we measure that is through an integrated care assessment that Medicaid has fully adopted, and we are hoping to spread statewide. The integrated care assessment tool that we're using was originally developed in New York State. And one of the handy things is there's an assessment for primary care and there's assessment for behavioral health settings, because I think to get integrated primary care, it's not just about primary care, it's also about some people are more comfortable or get the majority of their care from mental health or substance use providers. And so how do we sort of meet people where they are and have the integration go both ways? And so I think that is, that's a really important part of this, is that it does take the whole village to figure this out and to have good communication back and forth.
Others just join in or ask Judy or Mike questions, because I've got questions for both of them, but I also want to give you all an opportunity to interact.
I'll just add on, because Judy's last point about integration happening in both directions, I think is often forgotten. I mean, the collaborative care model was designed for primary care, but you can bring physical health resources into the behavioral health space. And our Medicaid subsidiary, Community Care Behavioral Health, has done exactly that. We published on a model called Behavioral Health Home Plus, where we bring in physical health resources to methadone clinics, to psychiatric residential treatment facilities, to places where people with serious mental illness or fairly severe substance use disorders we know they're getting care there. This is a population that often doesn't get much in the way of physical health maintenance, and bringing dental care into all of this. So, and there are value-based payment arrangements to sustain these programs, and the outcomes have been terrific. So that's not for everybody. I think the collaborative care model can touch a lot more people, the sort of average person, but bringing in primary care into the behavioral health space is a needed strategy too. As far as like how to move the needle or what do we need, I think Mike kind of alluded to this earlier. advanced primary care should not be the exception. It really should be the rule. I think if we raise our expectations for what primary care can and should provide, if it's written into our contracts with primary care clinics that like this is what we expect of you, I think things will change, maybe more gradually than we would like. I mean, some of this goes back to education and just residency programs and graduate school programs for social work. The more people that get exposed to working in a team-based integrated care environment, the more people are going to be looking for those jobs. The more jobs there are going to be. It's a feedback loop that we're not taking advantage of. And I mean, there were some questions about capitation that I think that I'd like really to hear Kevin's perspective on. But it doesn't have to be the same rate for every clinic. It's appropriate for performance-based contracting or other kinds of adjustments to say, a clinic that is providing team-based integrated care is providing more valuable care, and we're going to pay more for it. That is an incentive for them, and Judy had alluded to how do you measure model fidelity. That is an incentive for them to put the investments in and make sure that they are able to retain staff and provide integrated care for some or most of their patients.
Well, I think Judy did underscore a couple of points that are really important for from the practice's perspective, which is this whole notion of alignment. Then if all the payers are on the same page, that can help compel the practice to move down, the change process pathway, if you will. And of course, being able to have an agreed upon assessment for fidelity to a model, that helps too, because now everybody knows what the goalposts are that they're trying to reach. The last one though is payment, because you still need the investment and the financial support. So I don't know, Kevin, if you want to reflect on the capitated environment or other ways that payment can really move things along.
Yeah, happy to. So I was just reviewing the chat too, and most of my particular role in our world is actually in a capitated environment, and that is largely the way that we pay, particularly behavioral health providers. And a few of our key markets, they're entirely, it's very often there's an association or even a state sort of funded and maintained organization that negotiates, as one entity, and we pay that organization, on a cap. To the point about how do we kind of maintain fidelity to a model and incentivize quality outcomes in general. We do it a lot of different ways. I mean, there are always incentives and requirements to meet some sort of quality metric, and it can take a lot of different forms. We try to, as Judy put it, meet providers where they are, just like we're meeting members where they are. So sometimes that will take a form of just simply, pay for reporting, especially early on. And as we're establishing data exchange with a newer, smaller provider, we provide the support to do that, all the way up to full-on shared risk. And that the shared risk environment is a little easier when the providers are on the larger side. And we do a lot of that with multi-specialty, larger groups that are sort of large hospital-based. That is fairly straightforward. Reaching a little bit further down into the size and providers and into more rural areas and places where the need is really greatest is where also the lift to do this becomes harder. So what we have done is we've tried to group providers as much as we possibly can. So we have a small providers sort of incentive program that we use that helps with denominator management, if you will, right? Because it's with these quality metrics, if they don't have the right number of members to kind of put in the denominator, then there's too much volatility, and they're all up against their own revenue cycles, which we understand and want to support. So we, combine a lot of these things and do a lot of cohort comparison analysis. We do a lot of this in Louisiana. We're doing it in North Carolina. We definitely do it in New Hampshire, which has a very robust behavioral health coalition up there. So there's a lot of moving parts. I'm not being terribly articulate in summarizing all of them, but we do absolutely focus on a cap-based system largely with substantial quality incentives, substantial outcomes incentives, and push that as hard as we possibly can toward quality and toward member outcomes and toward member access. I think also I want to make one more brief point, and thank you for your indulgence, on investment. We are all in a short-term revenue cycle world, and that is an unfortunate fact of all of our lives. But the investment that we're talking about is necessarily many orders of magnitude longer than any one of our revenue cycles. So I think as an industry and as a group of peers, we have to take risk together and understand that despite what a short-term P&L might look like, despite what a short-term contract cycle might look like, the investment in the future has to be upfront. It has to be aggressive. It has to be a lot faster than what we're doing. It has to be workforce development. It has to be investing in residency programs and graduate programs, all of those things. And as much support as we can have from our regulatory partners in taking that risk, the better. And I'll stop there. Thank you.
Yeah, I'll jump in a little bit more about payment, and then we can shift to some of the other questions in the chat. So I didn't mention our primary care transformation model does some of that. So at the beginning, we use the integrated assessment tool, and if you Google that plus Washington State, it'll come up with the tool that we want, because that was a question in the chat. But we use a centralized certification method, and I think that's important for sort of both alignment and making it really clear what expectations are and making it easier on practices. And we have level 1 practices that are just starting on their journey all the way up to level 3, which is advanced primary care. And if you're a level 1 practice and maybe a level 2 practice, you can get transformation funds once we start this model to help support that and build up some of the infrastructure you need. And you can get quality incentive payments, but the goal is really to move everyone to level 3. And level 3 includes quality incentive payments, but also the payment changes to a capitated primary care. So a per member per month payment for the bulk of services that primary care does, which allows the flexibility to sort of figure out kind of which thing people need and how to provide that care. So maybe it's not exactly the, integration can happen in a number of ways, to Mike's point. So maybe it's not exactly what's happening in your practice, but you can use those resources differently, and you can structure your practice differently because you have sort of committed funds that come in. We have a decision package that we've submitted this year that will hopefully get funded to really increase that investment in Medicaid in Washington State, because I do think increased investment is necessary to get this across the finish line.
Well, both Judy and Kevin really have put a fine point on this whole notion of investment, whether it's in the transformation TA that's needed, or in the infrastructure rebuild, or whatever it is that's critical. And what I heard Kevin saying is, it's hard, and for a health plan. And most organizations are thinking about their quarterly, their annual cycles to really make that kind of investment, because the payoff is down the road. So what you see is some states deciding that after they look at what the expenditures are in primary care, that it's insufficient, and so they are requiring health plans in those states to put more investment into primary care and specifying that include behavioral health integration. And what that does is it levels the playing field. So all the health plans need to do that. And also, it becomes a requirement for practice that has long-term beneficial effects, you would hope, for the population in that state. So, I think that is something that we're seeing. And in fact, there are now 18 states that are reporting primary care spend. 6 of them have made the decision to require the reporting of primary care spend. 6 of them have decided to increase primary care spend by a certain amount over, a 5-year period generally, and then are getting very specific about where those dollars go. So that is, perhaps one approach here. Judy, if you can put your tool, send it to us or put it in the chat, we'll make sure it's part of the webinar package when we post it. And it is a question that we've heard in our interactions, whether it's with Senate Finance or with CMS. How do we measure the model? How do we define integration? How do we measure integration? And so I think there's a lot of work that needs to go on there, to have the kinds of tools and measurements that are going to help us to understand whether or not what we're hoping for is actually happening in the practices. Please keep having your questions come in. We've got a lot of great questions. We do have some related to telehealth. And so one of our participants in our webinar today really wants to understand, telehealth, as a model, or telehealth integrated into primary care, pluses and minuses. What are you all thinking about the role of telemental health in what you're trying to achieve with behavioral health integration?
Well, you probably have people who are better experts than me on the panel, but I'll start just so they can correct me. So, we're very bullish that telebehavioral health, virtual care in the mental health space has been very successful. It has achieved very comparable outcomes, and frankly, more reliability to show up for appointments, and been better for practitioners, using very scarce resources very efficiently. So we're very bullish on that. And when you bring it back into behavioral health integration, Kevin talked earlier about private sector solutions arising. There are a number of excellent private sector solutions that are very devoted to integrating with primary care. A lot of times when we talk with plans, they will say, we're going to focus on the big practices. And of course, that's the easier play, to focus on the big practices. But a lot of primary care is not big practices. It's very small practices, and it's not practical to think that you're going to be able to co-locate with every primary care physician in the country. And then Kevin spoke earlier about rural populations. Well, how the heck are you going to serve rural populations when there aren't any psychiatrists in those rural locations? The magic of virtual care is you can do it. Now, there's a challenge, and I've heard this said, that maybe it's not as easy to develop a relationship virtually, but we're getting better at a lot of these things. And I think we have to be open-minded about finding scalable approaches where we don't leave people behind just because they don't live in a big city, and or they live in a care in a part of the city where there are no practitioners. Again, right? We've got to be thinking holistically about not just the lucky few that go into the excellent practices that have done this, but everybody. As Alan said, how do we make this the expectation, and then facilitate it with technology-enabled solutions?
And Mike, I agree with all of that. And we could all remark on how odd the virtual world that we live in, how it would have seemed 3 years ago, and how normal it feels now. And so I think that's been a benefit to patients and members as far as access goes. Absolutely. I think the push pull that we sometimes feel a little bit from our regulatory friends is that they have a mandate to support the existing systems in the states, particularly where, these are sort of safety net behavioral health and primary care systems. And we understand that too. And we do actually focus fairly heavily as a company, just as an ethical point of view, on smaller providers for exactly that reason. So there's always, with bringing in new partners, there's we want better access, but let's make sure we're not adversely assigning risk to the local community mental health center or primary care practice that is sort of on a very tight revenue cycle versus a for-profit company that's getting all the good risk, right? So we have to manage a lot of that, and we do that fairly aggressively as well. But to your broader point though, I think you're absolutely right that the telehealth access has been largely a positive. We are moving as fast, as hard as we possibly can in supporting expansion of that. We started with thinking of what's our digital health solutions infrastructure going to look like. We've broadened that to what is our access solutions infrastructure going to look like, because it just doesn't matter. Everybody has a digital health solution. Everything is sort of merged and blended now. And we're looking at it from an access point of view and a material impact to the patient's point of view, and not so much are they going to be talking on a screen or in person.
Super. I mean, I think the point about access and convenience, from the patient perspective, but also potentially from a clinician, rather than having to drive around places or serve many clinics. They can be located in one place and serve a lot of people in a more efficient way. Also, I've heard from patient advocates that many patients feel more comfortable having these visits in their homes, and so that may also actually enhance the therapeutic process. I know we don't have good data on that yet, but it's a hypothesis that many are advancing. Another question's come through. Increasingly there are folks that are advocating, for better mental health services, better behavioral health services. We have seen in a couple of places where you've got some of the primary care advocates and the behavioral health advocates competing, and we always say, no, we should get on the same page. We're taking care of you don't divide people, their brain over here and the rest of their body over there. Like, let's everybody get together and think about the synergies here and how the shared infrastructure can actually support what we're trying to achieve. So we do really try to dissuade folks to be in competition. But another issue was raised in the chat about some of the behavioral health clinicians focusing on expanding their scopes as sort of their priority for advocacy, as opposed to thinking about advocating for this integration. So I'm curious if you've encountered any of that in your work, and what your response might be.
Well, I'll speak briefly. I mean, our behavioral health workforce nationwide is a limited resource. There are simply not enough psychiatrists or therapists of whatever credentials to serve the behavioral health needs of every American. So I think a huge advantage of integrated models of care is that there is a multiplier effect happening, where the psychiatric consultant with the care manager allows a primary care doctor to care for far more patients with behavioral health needs than the psychiatric consultant could do themselves, or that the care manager could do themselves. I think there's another advantage to integrated care over any of these other solutions. And I agree with everything that was said earlier about telehealth. Like, telehealth is terrific. It breaks down existing barriers. It helps reduce disparities, but it's not enough on its own. So one of the things is that primary care doctors who, let's say they even have behavioral health resources to refer their patients to, many of them never go there. They don't want to see a therapist. They don't want to think that they need to go see a psychiatrist. When it's all under one office, there is a huge benefit in terms of reducing stigma, because it's a team, and this person is part of the team, and so you're going to have more buy-in from patients. They also don't have to worry about who's seeing them go in and out of the psychiatrist or therapist's office. They're just at their primary care office. Nobody knows why they're there. And then there's an additional benefit of integrated care, which I don't think has been emphasized here, is that physical health and behavioral health do not exist independent of each other. They have a bi-directional relationship on each other. Somebody's poor physical health could affect their behavioral health. Somebody's poor behavioral health could affect their physical health. When you work as a team, you can think through all those problems dynamically together. What happens right now, I mean, I've referred patients with atypical anxiety to endocrine surgeons because I diagnosed them with hyperparathyroidism. Their calcium was high, and that was what was going on, and they were having weird paresthesias and other kinds of things. I had to take time out of my day to call up this surgeon and find some time that he could call me back so we could discuss this referral. I didn't get paid for any of that time. He didn't get paid for any of that time. It's a pain. If there was a integrated system, these kinds of conversations could happen within the electronic health record. You could walk down the hallway. It would be coordinated by the behavioral health care manager. That kind of coordination would happen more naturally and more frequently, and our patients would benefit.
Well, thank you, Alan, for painting that picture for all of us. And that is really the sort of care that I think we want for ourselves and for our families and for our patients. And I really want to applaud you all for your efforts to get us there. I'm so pleased to have welcomed you today to our webinar to share your insights and your work, and look forward to working with you on an ongoing basis. Stay tuned. We will continue our monthly webinar series. Next month, PCC will be releasing its 2022 evidence report on November 16th, so wait for an invitation for that. And then I already mentioned our conference, and we hope to see you in Washington, D.C. on December 14th and 15th. Please join me in thanking Kevin, Mike, Judy, and Alan for all of their work and for their contributions this afternoon. Have a great rest of your day.